aortic treatment. Now, we would like to invite Professor Stephen Cheng from Queen Mary Hospital, Hong Kong, to present the lecture. Evaluation of endovascular treatment of aortic arch. Professor, please.
Thank you very much, Mr. Chairman, and a very good morning to all of you. Thank you, Dr. Yok, for your kind invitation to Vietnam again, and it's my pleasure to see many friends again, both from Vietnam and also from Southeast Asia. So it is interesting to see the earlier presentation about all the options available using hybrid techniques in treating complex aortic diseases. And I can assure you that we have actually come through the same process about 10 years ago, trying to manage a very difficult situation with limited resources. In Hong Kong, we have a unique position. We are fortunate enough that we have a wide access to a number of devices, whether this is custom-made or whether this is off the shelf. They are now, we have experienced the use of many different devices, including fenestration and branches, landing in different zones, antegrade, retrograde branches. And having tried quite a number of them, I come to believe that we are slowly moving into a direction of how to treat aortic diseases. Like Professor Xu has said, they are very complicated, complex devices, but it has to be easily available and easy to be used by the average surgeon. Otherwise, it's not going to survive. I have come to the conclusion that most of the time when you do things in the arch, you either land at zone 2, where most of them would be dissections, because I think landing in zone 2 for aneurysms would be a little bit risky, or you go all the way and you want to land in zone 0, where you have a good length of aorta. I think for the abdominal aorta, when we do fenestrated graft, we tend to move our landing zone more proximally. I do think that the same probably goes for the aortic arch as well, as you have to move the landing zone more proximally. Of course, there are issues about anatomy because there is a turn in the arch, so the acuteness of the turn affects your landing zone, unlike the abdomen, and also the status, the current state of the ascending aorta itself also affects the choice of devices and the outcomes. So the major consideration for landing in the arch would be, firstly, of course, is this an emergency? Because if it is an emergency, you have to do some off-the-shelf devices, or you have to improvise to do it early. Otherwise, you have the luxury to getting a custom-made devices at the wait of about 4 to 6 weeks. Like I said, you have to choose a good proximal landing zone. Thirdly, you have to consider long-term branch stability. This is not something that a lot of people put attention to, but I do believe that long-term certain branches may have problems, and the patient will have long-term issues and secondary interventions. And of course, finally, the ease of use of the technique and whether it is widely available, whether it can be used to train younger surgeons. These are very innovative procedures in China. Of course, doing a chimney procedure using Professor Xu's device would minimize the risk of endo leaks. Or I believe also the use of in situ fenestrations, again, very popular in China, I know, because they have a lot of patients with dissections, but we do not have a lot of experience with this because simply we do not have a lot of acute dissection patients who would let us do the procedure. So we are lazy. So what we have in Hong Kong is that we have the time to allow for a custom manufactured device. And when you do for complex diseases in the arch, the first thing you want to do is you want to land in zone 2 because that seems easy. So we have this custom-made single fenestration devices for a long time. That's been using that manufactured by Cook Medical for a long time. And with the issue about this is because the Cook stands are longer, and therefore it requires about 27 millimeters. Why is it going that way? of distance between the fenestration and the front of the stent, and therefore you need some sort of scallops, you need some sort of distance for that. I realized that for fenestrated devices in the arch, there are issues of endoleaks. If you don't align, especially if you do custom devices and you do not align the fenestration well, you would run the risk of developing endoleaks. You would run the risk of misalignment because you can't rotate the arch, the device well to mesh the target vessels, or the branch can be crushed. Say in this patient, after about a year's time, we see that the entire stent was actually crushed on the side because of slight migrations in arch. So not really something that I would like. So when we do the arch now, we are evolved into, I think, single branches rather than fenestrations. We are going more for off-the-shelf devices now than to do for custom single branch devices. And we sort of dispense with double branches and we move directly now to doing mostly 3 branch devices. I think currently what we're doing is either an off-the-shelf single branch device for some patients, or we go for 3 branches. So single branch, because of the limitation we discussed earlier, now we tend to favor these immediately available retrograde single branch devices, which mostly, when we want to place it, we place it in zone 2 to preserve the left subclavian artery. Then unibody devices, and they are also modular devices. These both from mainland China. The top is the caster, which is a unibody design. The issue about unibody is that the front is attached to the stent, so there are some comments whether that actually would place a lot of force in the top of the landing zone and they cause a high risk of retrograde dissection, whereas this is a LifeTech design, the other Professor Shu's design with modular graft. So that is my concern about unibody devices. That's the caster, because it's held at the top, and there is a tendency for the graft to move backwards. And if you're not careful and you deploy too slowly, then you would have a slight collapse of the graft. It doesn't open very well on the lesser curve. The LifeTech device has a mobile port that you can bridge that allow mobility at the top, and supposedly it bridges better. So all these devices comes with a preloaded catheter for the fenestration that you either snare from the top, and then you would then lead a through wire to the subclavian artery, and you can come in from the top or from the bottom in both cases by bridging the left subclavian artery, which is most of the case with a bridging stent. But do remember that still you would need a proximal landing zone, otherwise you would have a type 1A endoleak. So bridging the stent is only one thing, but you would need to have a good seal in the front, and sometimes we just cannot get it for the single branch devices. That is the Coke Company version, the second generation of LSA branches. It comes with a recess in here with a preloaded catheter. I think with this device, the problem in Asian is it requires a 25 millimeter distance between the back of the left common carotid and the back of the left subclavian that we simply do not have. So I think the distance is too long to be suitable. You have to get this long distance before you can safely deploy the graft. And likewise, it's supported by a second stiff wire through a preloaded catheter, and you put a sheath up here, and then you get the branch in from the leg. All very nicely, except the anatomy where it may not exactly match the anatomy in Asians. Core has recently come back to, at least my part as well, I believe for also Thailand and Singapore. They are trying to push the TBE, which although you still see there's 25 from here to there, actually you count it from the front, it is probably only about 15. So it would give us a bit less requirement for the anatomy. This is an off-the-shelf thing, which is also very attractive. It has very large diameter subclavian branches, still a retrograde branch with a preloaded catheter, I do believe that the Gore TBE has the high tendency to peak because it's a rather stiff device. So beware that for arches, the front may not conform that well. They do not have that conformable control for the TBE yet. And you also have to have the choice of whether you want to land as close to the carotid as possible for maximizing the seal, or you want to land to the portal. So you have a chance of moving a bit more forward to get more seal, or you may have to move a bit more backwards to accommodate the angulation of the portal. So there's no both ways. I think that is also one of the major consideration for TBE. So for dissection, it's probably fine. You can land this a little bit more backwards to align the branch very well. It goes in the portal, and then you sacrifice the landing zone in the front. I think that is the downside you would have to accept if you use an off-the-shelf solution. Of course, occasionally you can use the TBE off-the-shelf to go into zone 0. We seldom do it for zone 1. So you can put the single branch into the nominate in cases you have a previous zone 1 landing failure with a endoleak there, or you have a short ascending, which is very commonly done by our cardiac surgeons with an angulated ascending graft, that it would be very difficult for the traditional devices to pass. The TBE does have this advantage that it has a very short tip and you can negotiate that. So it's a very complex, interesting patient with very large aneurysm, can't really wait, he's symptomatic, he has pain and hoarseness, and there is this previous ascending graft which is very tortuous and very angulated. So we managed, for example, to do this with a Gore tag first to support the descending, and then with the dry seal, we have to turn this first angle in the arch to support this, to put a second tag there to get a good landing zone here, which is very accurate. And then we come in from the nominate, and then we will put the TB in supported by this second thoracic graft, and that is this branch going into there. So it all fits very nicely because the short tip and the large diameter nominate branch goes up to there. And for good measure, we'll put in the short ascending cuff to achieve that bit of seating from the top. So very nicely, very expensive procedure, probably more than $100,000 that you want to spend in one patient. So that may not be that attractive. So we come to the ultimate question is, why don't we just do it, for all patients to avoid all these fiddling in the arch and try to land in zone 0 and do what these days would be a 3-branch device. So that has its own anatomical considerations, largely for the length of the standing, the healthiness of the standing aorta. You have to look at the coronary, of course, all these branches. I don't want to go into that. I think the first key you want to do that is you must have a healthy ascending aorta. And for Coke, where we do a lot, they mandate a 38 millimeter diameter ascending as the upper limit that you can use. If you go beyond that, like we did in a big Caucasian man, we thought we can do a 39 or a 40, you get a retrograde type dissection on day 2 because the inherent health of the ascending is not good. So the consideration, if you want to do a zone 0, is it a custom-made device which you have to wait and it's off the shelf? The delivery system tracking, how big it is, does it track up to the arch that well? Do we have to cross the aortic valve because the Cook arch branch has a very long delivery tip that you have to get a stiff wire through the aortic valve? Do you need blood pressure control? Some sort of rapid pacing or IVC balloon occlusion to reduce the blood pressure as you deploy the graft? How do you align the branch? Do you have to do exact branch alignments? And of course, stroke prevention and the risk of retrograde dissection. Are there any barbs and bear stands in front? So that's our experiences of doing these 3 arch in arch. We've done today 54 in Queen Mary Hospital. As you can see, we start off 2 branches, and then now we're doing almost 3 branches. We started with Coke, And now we are sort of leveling off and we're moving off to the light tech model, which I believe is actually superior. And we're moving all to 3 branches. So that is the Cook device with 3 diamond-shaped recess. I'm sure you've heard about this with 2 preloaded catheters, 2 retrograde side, 2 antegrade side branches, 1 retrograde side branches. It's like CMD, so it has to have weight. It has a long delivery tip that you have to go past the aortic valve. Blood pressure control, some say yes, some say no. So it does require accurate positioning because the diamonds are rather small. And it has, I think one of the major issues, it has a large innominate branch that is 16 French, and you cut down on the right neck to deliver this. And there are barbs that may predispose to retrograde dissection. So therefore, a maximal 38 millimeter proximal diameter. That is basically the Cook device. You need to have a stiff wire through the aortic valve into the left ventricle. We use the IVC balloon occlusion that stands along. There's the barbs, and you have to cut down on the neck to put in this 16 French innominate side branch into the innominate artery, and then all the rest would be relatively easier if you align well the 2 and the second and the third branch for a Cook arch branch. So the wire through the ventricle, through the aortic valve, may not be a good idea. If someone is looking at it, you get a hole in the ventricle in this particular patient because you lose control of the stiff wire that gone into the left ventricle. So I don't think that is a very good idea. This second patient that we done is in somewhere else. You lose the wire in the innominate branch, and the delivery system simply punch a hole into the coronary sinus, which is some of the issue with these stiff devices. And you know that some of them do have a tendency to strengthen, and you look at the marker as the graft strengthen, they tend to migrate backwards a little bit. So the diamond has to be aligned pretty well, otherwise you may have difficulty cannulating the side branch if you move backwards. So our take for this, if you use this, is try to get the graft as far forward as possible, very close to the coronary, so that you have a stricter path to enter the retrograde side branch, antegrade side branch. But if you're going too far forwards, you king the subclavian branch, and then you have long-term branch occlusions. So we are switching over to this LifeTech device from Professor Xu with a very short tip, so you don't have to cross the aortic valve. 3 branches with a large recess that you can cannulate, comes with different sizes, and it's literally off the shelf. I think you can order it with no weight, and the good thing is it's an 8 to 9 French innominate side branch that you can come in from the arm, and you do not have to cut down on the neck anymore. So that device comes in very easily, no wire through the aortic valve, deploys pretty accurately, and then that's out coming from the arm percutaneously, innominate side branches coming with a short cut down in the neck, and then retrogradely through a subclavian side branch. So I do believe that this is advances in the future. It goes for these very difficult, very angulated ascending aortas, and because of the short tip, it actually can do this relatively easily. So you can deploy this. I don't think any other device can turn this curve in there for treating this sort of situation. It does have some issues. If you don't, you're not careful with blood pressure, you can see the graph actually moving a lot. In this patient, we don't really care about blood pressure control. So you can see the graph jumping and the system jumping a little bit, but in the end, it stays in place. So it's kind of scary as it jumps, but it stays in place. There is one patient that we have to do this in an acute arch, and as we deploy this graph, then the graph still tend to flatten, and it does move backwards a little bit, so that has to be taken into account because it does not go to the top anymore. But the good thing is, because of the right access, you can actually come in and you can deploy the graph crossed. So this one actually goes that way, and that branch goes this way, and accommodate all sorts of branch closures. So we've done a total of 14 very good results for this next generation graph. I believe old patients, mostly aneurysms, with only one patient with a small stroke. only on CT scan. So I'm very happy with this, and I do believe that that is the direction we are going, to go for zone 0 with a off-the-shelf device with multiple configuration, with short tip, with no pressure control needed, and percutaneous access, and no proximal sense. So that is the path we are doing in terms of arch. We're doing off-the-shelf, either single branches, retrograde for zone 2, or we do it in zone 1 plus a cuff, or using an off-the-shelf 3-branch device these days. So thank you very much for the attention. I look forward to joining us in India this year.